welcome to the Chelmsford Medical Centre reception. Now I'm here today to talk to the cosmetic surgery team about any questions and concerns that you may have about liposuction and lipotransfer. We'll be finding out exactly what the procedure entails, answering some of the questions asked by previous patients, finding out the risks involved and looking at some past client testimonials. So I've signed in, I've had my coffee, and now I'm off to meet Professor Frame, who's part of the cosmetic surgery team here at Chelmsford Medical Centre. Professor Frame is Professor of Aesthetic Plastic Surgery at Anglia Ruskin University and is an executive committee member of the British Association of Aesthetic Plastic Surgery. He has over 25 years' experience specialising in aesthetic and reconstructive surgery. So, Professor Frame, I think a lot of the people watching this know about liposuction and lipotransfer, but just in case, can you just tell me what the difference is?
They're actually chalk and cheese, really. Liposuction is basically a procedure where you take out fat from one part of your body, and the sort of context of that would be the hips and thighs of a girl, or maybe the tummy. It's only really useful, though, when you've got good quality skin, so it tends to be better applied to younger women that are maybe marginally overweight or have tried their hardest to lose weight but can't lose it from those critical areas. And lipotransfer is in circumstances where you're trying to build up or augment an area with fat. For example, a girl with very small breasts you're trying to make marginally bigger by introducing new fat. It can also be used to fill in holes, and it can be used to augment buttocks, and it can be used to put fat into the backs of hands of ladies that's showing the aging process. So lipotransfer is both cropping of fat and putting back of fat in certain areas, whereas liposuction is literally just taking of the fat out.
So what fat areas can these procedures be performed on? I know a lot of us have problems with muffin tops and bingo wings and of course cellulite.
Yeah, and the other one's cankles, I've heard as well. They're the calves join the ankles, known as cankles. Those are areas that are pretty good for liposuction, providing the skin quality is good. And we're not talking about something with what we call lymphedema, which is like watery congestion of the tissue. If it's purely fat, then it can be basically taken out. The key, though, is it's got to be done very carefully, and there are sort of fairly novel ways of doing it, which carry much less risk to you as an individual. Cellulite isn't such a good area to do liposuction on. The sort of lady with cellulite is the generally larger lady that everything is stretched out and left the skin vessels and everything sort of taut. And they're what sort of cause the dimpling of the thighs and legs.
Well, actually, I've got a cellulite. Do you think you'd be able to get rid of it?
Well, you're a young person, and then you've got to think about, you know, mostly people with cellulite have a bit of a body in two halves. So the cellulite around here on a young person is usually contrasting with the skinny bits at top. And those girls often have a thing called lipodystrophy. And they're what you're not trying to do is cure the cellulite, is take the shape down so that in clothes you look better. So cellulite's quite difficult to treat. There are actually other ways of doing it, sort of novel things. You tend to sort of get this new equipment when you work in the university. But one of the things we've got is an ultrasound machine that will bang into the outer layer of your skin and drift off that top layer of fat and tighten your skin, and probably that would be better served for cellulite rather than liposuction.
What about if I've had lipotransfer? What happens to the areas of the body where I've had the fat injected?
The crunch here is really about your starting point. If you're a nutritionally active person and your calories are up, and then I take fat off you and you continue to be nutritionally active, the fat that I've transferred, by and large, will go through a number of phases, one of which is some of it will die off, and the so-called stem cells that we transfer will then come along and produce new fat cells, and you'll probably get about 80 to 90% of the fat regenerating. Now, if you lose weight, you will lose fat, also the fat that I've moved into your other part of the body. So you've got to do this when you're homeostatically stable, if that's the right word, when you're actually nutritionally stable, where you've lost your weight, where you've kept that weight on, you've maintained it. If you put weight on, the fat where I've put it will get bigger. If you lose weight, you will lose it from the area I've moved it.
Now, I know I want this, I've thought long and hard about it, but I'm still a little concerned about the risk of scarring and also the immediate and long-term risks to my health.
The scarring from liposuction and lipotransfer is minimal. They're small little incisions, a few millimetres in length, and usually they're concealed. We try and hide them to an area hidden by your clothing. The scars, therefore, aren't really sort of entering the equation. So what we've just looked at are the specific risks for lipotransfer to breasts. Liposuction itself carries risks and depends on the area where we harvest the fat from or we take the fat from. For example, on the abdomen, many of you will remember Colin Hendry's wife, where the liposuction cannula perforated the bowel at least 20 times. So the whole issue about this type of work is identifying the correct person for this procedure, identifying the person that's at risk of this type of surgery, meaning medically and physically, but more importantly, emotionally, choosing the wrong person. For example, a lady or man with dysmorphism is likely to put them into suicide risk because they'll never be happy with whatever outcome we give her. And it's identifying all of these issues that are paramount to patient safety. The other complications we have to talk about are with general anaesthetics in general, because any anaesthetic where you're asleep carries a risk. Your blood pressure drops, your pulse rate can race away, you are being supervised while you're in a sleep state by another practitioner, actually an anaesthetist. This hospital prides itself on choosing the best and most skilled anaesthetists available, who all practice within the National Health Service, and they all have a very caring attitude towards their patients, and given any form of risk, they would refuse to do the surgery. The infection rate really is dependent on the specialty, and the sort of work we're talking about within plastic surgery is incredibly rare to get any form of infection. The reasons are multivariable, mainly because plastic surgeons don't traumatise the tissue. Infection is related to heavy-handed, traumatic type of surgery in at-risk patients such as diabetics. This is a day surgery hospital, and to my knowledge, there is no case of MRSA or Clostridia difficile that has occurred in any plastic surgery patient carried out at this hospital.
Professor Frame, thank you so much for spending time with us today, and I'm sure that you've addressed many of the queries that a lot of us have about these cosmetic procedures. We hope you found this short video useful and that it's helped you a little on your journey. From all the team at Chelmsford Medical Centre, goodbye and thank you for watching.